finish in 40 minutes. Yeah, okay, without قطع, inshallah, I will recap. Okay, yeah, so this talk is about very specialized disorder of the hip joints. It's a group of mechanical disorders called hip impingement syndromes. This is actually a very specialized area in musculoskeletal radiology, and most of the information you find in this talk is kind of more musculoskeletal fellowship level. So it may be a little advanced, but we'll take it slowly. So the theme of this talk is really to talk about the labrum, the anatomy, how labral tears look like, and then we will look at the imaging protocols, how we image the labral pathology, and then we will move on to the topic of this talk, which is all the different types of hip impingement syndromes. So the basic anatomy of the hip joint, I'm sure you know this part of the hip anatomy. The hip joint is a hyaline cartilage, so the lining of the hip joint is covered with hyaline cartilage. The cartilage itself in the acetabulum looks like a horseshoe appearance with the central area called the bare area of the fovea centralis, which is just really fiber fatty tissue. There is no hyaline cartilage in the middle. The margin of the acetabulum is covered by the labrum, which is the topic of this talk. And the labrum, I'm sure you know this, is a fiber cartilage. At the bottom of the acetabular fossa, we have the transverse acetabular ligament, and we also have ligamentum teres. The capsule of the joint, there are three fibrous condensations of the capsule of the joint, which they form the strong ligaments of the hip joints, and these are the hupofemoral, iliofemoral, and ischiofemoral ligaments. These are capsular condensations of the hip joints. The labrum is a fibrocartilage, just like the meniscus or the disc in the temporomandibular joint or the triangular fibrocartilage in the wrist. So it's a different type of cartilage. It's a triangular in appearance, and the reason why it is important and there's been increasing interest about labral imaging and understanding the labrum is because the studies have shown that the labrum is innervated by by pain and nerve fibers. So when there is labral pathology, it's normally symptomatic and it's a pain generator. So that's the reason why there is increasing interest in the labral imaging and also surgical management of labral pathology. The labrum has functions in the hip joint. It's considered a stabilizer of the hip joint. It is also a shock absorber. It is provided with proprioceptive nerve fibers, and it helps with joint lubrication. How do we image the labrum? Firstly, when we have patients referred for labral pathology or femoroacetabular impingement, we start with radiographs. And this is the set of radiographs we perform on all patients who presented with symptomatic hip, particularly mechanical hip disorder. And most of these patients are young patients, so they are not like the degenerate hip disease. So what we do is we do frontal radiograph of the pelvis, and then we do frontal radiograph of the affected hip. We do Dunn's views to look for the femoral neck offset and cam deformity. We do problateral and post-profile radiographs. The post-profile radiograph is actually very helpful because it helps assess the posterior joint space. The frontal radiograph of the affected hip normally helps with assessing the superior joint space narrowing, but post-profile radiograph helps assess the posterior joint space narrowing, which you don't normally see on the frontal radiographs. The MRI protocols for imaging labral pathology, there are two techniques that we perform at our center. There is the technique which is very commonly used in most of the centers, which is the arthrographic technique. And this technique can be performed on the 1.5 or the 3 Tesla scanners. The second technique, which is more recent technique that has been gaining quite a bit of interest and popularity over the past 10 years, which is the non-arthrographic imaging of the hip joint and the labrum without injecting the hip joint with gadolinium. But this technique has to be performed on a stronger magnetic field on the 3 Tesla scanner. So this is the arthrographic protocol. This is what we do at our center if the patient was referred for arthrographic MRI of the hip joint. I'll go back to the technique. So the techniques are two different techniques we use at our center. The first technique is the arthrographic technique, which is normally performed using the 1.5 or the 3 Tesla scanner. The second technique is the non-arthrographic technique, which really does not involve any dilute gadolinium injection in the hip joint. This technique requires a stronger magnetic field, which is the 3 Tesla scanner. This is the arthrographic protocol for the hip joint imaging, where we inject the dilute gadolinium in the hip joint under fluoroscopy. The sequences we perform is the T1 fat saturated sequence in 3 planes: the coronal, the axial, and the sagittal. But we also perform coronal T2 fat saturated sequence. And the reason why we perform coronal T2 fat saturated sequence is to detect any paralabral cysts that can be seen in patients with labral tears. And this is how it looks like. So if we scroll through the hip joint using the arthrographic technique, there is gadolinium in the hip joint, and we see the labrum, which is this triangular structure, which is hypointense signal on the coronal T1 fat saturated sequence, and we can assess it in quite clearly here because of the optimization of the contrast between the fluid, which is the gadolinium, and the labrum itself. So this is the technique that we use for the arthrographic imaging. This is the axial T1 fat saturated sequence, and as you can see on this, there is contrast migration within the labrum itself. So this contrast migration within the labrum itself is diagnostic for labral tear. So this is how the detection of labral tears on arthrographic technique of the hip joint becomes a lot easier because you can see the contrast moving within the labrum and you can detect labral tears. This is the sagittal T1 fat saturated sequence, and again we see contrast migration within the anterosuperior labrum, diagnostic for labral tear. The second technique, as I mentioned earlier, is the non-arthrographic technique, and this technique does not require any injection of the hip joint with gadolinium. And as I mentioned earlier, this technique requires 3 Tesla scanner. We cannot do it on the 1.5. We have to do it on the 3 Tesla scanner. The sequences we do in this technique include axial T1 and also axial T2 fat saturated. And these 2 sequences are performed for the entire pelvis. So they would cover the affected hip as well as the unaffected hip. We also perform coronal T1 and coronal stir of the entire pelvis. We do coronal proton density fat saturated sequence, also sagittal PD fat saturated sequence. We do axial oblique T2. We do proton density radial cuts. We will look at this in a minute. And we also perform axial T1 of the knee joints. And the reason why we perform axial T1 of the knee joints is to perform the FAI quantification, especially assessing femoral neck version. Because the way that we assess femoral neck version, we have to have the knees, so then we can account for the position of the leg before we can quantify femoral neck version. So these are the images of the hip joints using the non-orthographic technique on the 3 Tesla scanner. So there's no gadolinium injection in the hip joint whatsoever. But also you can actually see very well how the labrum looks very clearly here, the triangular hypointense structure at the margin of the acetabulum. So this is how the labrum looks like on the non-orthographic technique. Also on the SAT PDFS, we can see there are labral changes, the signal change here. We can see chondrolabral detachment. This is the labrum, and this is the cartilage and the acetabulum, and we see separation between the labrum and the cartilage. So this is diagnostic for chondrolabral tear, and this is all performed without having to inject the hip joint with dilute gadolinium. I mentioned earlier in the protocol that we do something called radial cuts. And these radial cuts is actually not a new technique. This technique had been performed quite a long time ago when MRI scanners were first invented. And this is the technique that used to be performed for meniscal imaging. For the advancement in the technology of the MRI scanners, back then at the time, the only way you could actually image the menisci is by doing radial cuts. But then this technique of performing radial cuts has come back kind of to the imaging, to the modern day imaging technique for the labrum. Remember also that when we look at the acetabular labrum, we use the clock phase. But also we need to always remember that 3 o'clock position is always anterior and 9 o'clock position is always posterior. So when you perform these radial cuts, you kind of perform all these cuts using the clock phase. So you have a plane that goes from 9 to 3 o'clock, 10 to 4 o'clock, 11 to 5, and so on and so forth. And these are how the radial cuts look like. So for example, this is the 9 to 3 o'clock radial cut that will show you the 3 o'clock labrum here and the 9 o'clock labrum here at the back of the acetabulum. And then again, you move on, and then you have the 10 to 4 o'clock position. You get radial cut here, and you can appreciate the labral changes here on the labral tear. And then you keep moving until you cover the entire labrum. But these are thick slices. These are not isotropic slices. These are very thick slices, and they are performed in this manner. They are performed using the clock phase manner. And we keep going until we cover the entire acetabular clock phase of the acetabulum and the labrum. So why do we perform the 3 Tesla non-orthographic technique for imaging the labrum? It is a non-invasive procedure. There's no pain due to the injection of the hip joint. There is also no risk of infection, no risk of contrast allergy due to iodinated contrast injection of the hip joint. And also for some of the athletes that we have in our patient population, it's easy for the patients to return back to the competitive season after the MRI because there's no injection performed on the hip joint, so it's easy for them to return back to their sports. And also no radiation involved because we don't use fluoroscopy for this method of imaging. Okay, we move on now to the labral tears, and we will see how the labral tears look like. So what are the causes of labral tears? The first case of labral tear was diagnosed back in 1957 by Peterson et al. And this was an open arthrotomy in a patient with posterior hip dislocation. So that's when the first case of labral tear was diagnosed using open surgery of the hip joints. But also there are other causes other than trauma, for example, degenerative disease and labral degenerative tearing, the impingement and the mechanical disorders of the hip joints that we will look at in a minute. Hip joint instability also a cause of labral tears, such as capsular laxity and hypermobility, acetabular dysplasia. Also some kinds of sports that involve pivoting of the hip joints on an axially loaded femur, such as, for example, ballet or martial arts. These are very bad sports for the acetabulum because they are normally they cause impingement of the hip joint and tearing of the labrum. When we describe labral tears, you can describe them using the clock phase, as I mentioned earlier. 3 o'clock is always anterior, 9 o'clock is always posterior, 12 o'clock superior, 6 o'clock inferior, and then you can use the clock phase for describing labral tears. But if you feel like it's more convenient to use the quadrants of the acetabulum, you can use, for example, anterior labral tear, anterosuperior labral tear, the supralateral labral tear, and posterior labral tear. So you can just use the quadrants rather than using the clock phase. Normally, when I report labral pathology and labral tear, I use both. I say, for example, there is anterior labral tear extending from 1 to 3 o'clock position, or I would say anterosuperior labral tear extending from 12 to 2 o'clock position, and so on and so forth. Remember, the majority of labral tears are actually either anterior or anterosuperior. So most of the labral tears you are going to see, they are in this region here, either anterior or anterosuperior. Paralabral cysts is a secondary feature of labral pathology and labral tears, and we see them on the coronal T2 fat saturated sequence. It's quite important that we detect paralabral cysts because they can grow really large and they can be symptomatic. And the problem with paralabral cysts is that when orthopedic surgeons perform arthroscopy of the hip joints, they may not be able to see paralabral cysts because they just look within the joint capsule and they have really no way of knowing if there is an extra-articular paralabral cyst. So if we detected a paralabral cyst, we would mention it in our report, and we would say, for example, there is superiorly situated paralabral cyst or posteriorly situated paralabral cyst. And this would help the orthopedic surgeons to perform capsular incision and then draining or removing the paralabral cysts. And also, it's quite important that we differentiate paralabral cyst from iliopsoas bursa. So, for example, here we have a patient who has both. Has a paralabral cyst, which is here, the blue colored cyst, but this patient also has an iliopsoas bursa on top of the paralabral cyst. So we need to kind of make a distinction between the paralabral cyst and also the iliopsoas bursa. It is also important that we don't overcall the labral tears because of the labral sulcus. The sulcus normally looks smooth and shallow, and they are most commonly seen posteriorly, for example, in this patient here. But labral tears are more irregular here, more ragged, more irregular, and they are commonly seen anterior or anterosuperior, and they are associated with paralabral cysts. So this kind of helps you distinguish between a sulcus, which is normal developmental appearance of the labrum, versus a tear, which is more a pathology and needs to be treated surgically. So always remember that the sulci are more common posteriorly, but tears are more common anteriorly and anterosuperiorly. Okay, now we move on to the hip impingement syndromes, or the mechanical disorders that can develop in the hip joints, and they can be symptomatic, and how they look like on imaging. You can divide hip impingement syndromes in different ways, but the way I divide them is either FAI, which stands for Femoroacetabular impingement, or Non-FAI hip impingement syndromes. There are different ways you can also divide them into intra-articular or extra-articular, but whatever way you do it, as long as you remember what these disorders are and how they look like. So we start with femoroacetabular impingement groups, and the disorders that are seen under this group include pincer, the CAM, or both. And remember that combination of CAM and pincer is the most common type of femoroacetabular impingement. The first author that described femoroacetabular impingement is Gans, and you will see the name of this author on almost every other article published about femoroacetabular impingement. Okay, so maybe if we have one of the residents to take a look at this radiograph and just describe the imaging features.
نختار الدكتور إيناس. دكتور إيناس ويانا.
ألو، صباح الخير.
صباح الخير.
AP view of the X-ray of the pelvis. AP view show the right hip, the acetabular over coverage, the femoral head. يعني هو هذا التايب مال البنسر Femoroacetabular impingement over coverage.
Okay, do you know what the name is for this acetabular over coverage of the femoral head?
يعني هو البنسر.
Yeah, okay, so yeah, it's pincer, that's right, yeah, but maybe we will just talk a little bit more about this one. So pincer, as you mentioned, yeah, you are absolutely right. This is a pincer type of acetabular over coverage of the femoral head. There's two types of acetabular over coverage of the femoral head. There's the focal and there's the general acetabular over coverage of the femoral head. Pincer disorder of the hip joint or the pincer femoroacetabular impingement is more common in women than in men. And normally younger women in their 30s and 40s who present with the pincer type of femoroacetabular impingement. There are different ways to quantify the acetabular over coverage of the femoral head, and these are kind of four of these methods that we use. Every time we have a patient referred for femoroacetabular impingement imaging, we perform all these measurements. So if we notice on the radiograph there is acetabular over coverage of the femoral head, then we would assess the acetabular version, we would assess the acetabular depth or femoral head depth within the acetabular socket, we would do the lateral central edge angle, and then we would do the tonus angle measurement. So we do all these measurements when we have a patient with suspected pincer femoroacetabular impingement. Now, the one that you looked at is called coxa profunda type of pincer. So, for example, if you looked at the hip here, this is a normal hip. And with this normal hip, what you're seeing here, you're seeing the acetabular fossa lateral to the ilioischial line here. So this is how a normal acetabulum and a normal hip looks like. And because it's normal, there is about a third or a quarter of the femoral head remains exposed, i.e. not covered by the acetabulum. So that's a normal appearance of the hip. So always make sure there's about a quarter of the femoral head that lies lateral to the acetabulum without acetabular coverage. But in this case, the coxa profunda, what you're seeing is the acetabular fossa lying medial to the ilioischial line. And because of that, central migration of the femoral head has happened in the acetabulum, and because of that, now we have the femoral head lying medial to the lateral margin of the acetabulum. So there's no under coverage, there's over coverage here of the femoral head in this patient with coxa profunda. Now, the other type of femoroacetabular, pincer femoroacetabular impingement is protrusio acetabular. So how does protrusio acetabular differ from coxa profunda? again, remember that what we said with coxa profunda, that the acetabular fossa looked medial to the ilioscale line here. But with protrusio acetabuli, what happens is the femoral head itself now is situated medial to the ilioscale line. So this one is worse than coxa profunda because now there is even more central migration of the femoral head within the socket of the acetabulum. So this is called protrusio acetabuli. Now both coxa profunda and protrusio acetabuli are considered generalized type of overcoverage of the femoral head. So now we move on to this case. Do we have a resident to look at this case?
دكتورة شيماء علوان.
صباح الخير أستاذ.
صباح الخير، تفضل.
Pelvis X-ray AP view showing right side femoral head showing significant femoral head ejection. There is bump on the lateral aspect of the neck. يعني this is indicate or suggest cum impingement.
Okay, do you see any abnormality in the acetabulum?
The acetabulum looks to be peak-like at the lateral aspect in comparison to the left femoral head. Acetabulum looks more, يعني acetabulum looks to be peaking-like.
Okay, so now this is actually the focal type of pincer. So remember we said there is the general type of the stellar overcoverage, the coxa profunda and protrusio acetabuli. Now this one is different. This one is called acetabular retroversion. Now, how does acetabular retroversion look like? The normal acetabulum here on the left side, when you look at the anterior margin of the anterior wall of the acetabulum and the posterior margin of the posterior wall of the acetabulum, they should look like an inverted V shape. So this one is an inverted V shape because the anterior margin of the anterior wall is medial to the posterior margin of the posterior wall. But when we look at this patient with acetabular retroversion, what you're getting something called the crossover sign or the figure of 8. Now, what we have is that the anterior margin of the anterior wall is lateral to the posterior margin of the posterior wall in the cranial part of the acetabulum, but then it goes back and becomes medial to the posterior margin in the caudal part of the acetabulum. So you have the cranial part of the acetabulum is retroverted, and because of that retroversion, you get the crossover sign. So it crosses here, and then it goes back medial. So that is the crossover sign of the figure of 8. And the second supporting feature of acetabular retroversion in this patient, which is actually on both sides, and you see how the anterior wall of the acetabulum crosses over the posterior wall here and also crosses over the posterior wall there. And the second supportive feature for acetabular retroversion is the ischial spine sign. So normally the ischial spine should be facing or should be directed posteriorly. So you don't see it because it is always directed posteriorly. But when there is acetabular retroversion, the ischial spine sign becomes directed medially in this direction. And because it is directed medially, you start to see it on the radiograph. Normally, you don't see it. But if you saw the ischial spine sign pointing medially like this, always look for the crossover sign or the figure of 8, because that means there is crossover here because the acetabulum is now retroverted rather than antiverted. So remember this appearance here. So always when we assess the acetabulum, we don't really call it acetabular retroversion unless there is ischial spine sign. And we also check the position of the pelvis, make sure that the position of the pelvis is well centered. And the way to assess that the tip of the coccyx should be lined up with the symphysis pubis. And also the tip of the coccyx should not be more than 2 centimeters cranial to the symphysis pubis. So you need to check the centralization of the coccyx as well as the height of the coccyx. If you have more than 2 centimeters positioning of the coccyx above the symphysis, you could actually create artifactual crossover sign because the pelvis is tilted forward. And if the pelvis is tilted forward, you may create false crossover sign. So always make sure the position of the pelvis is correct before you call it crossover sign, and also always look for the ischial spine sign here. Okay, now do we have another resident to look at this radiograph?
دكتور أحمد فائز ناصر.
السلام عليكم. نعم أستاذ.
عليكم السلام. تفضل.
Plain X-ray of the pelvis. This seems to be a frog lateral view. There is abnormal morphology of proximal femoral head, osseous bump, simple anterotubular aspect, giving a pistol grip deformity. Features suggest of cam type, femoroacetabular impingement.
Yes, absolutely. So this is the cam type of femoroacetabular impingement, which is a bony bump or called sphericity of the femoral head neck junction. You can call it whatever, any name you like, but as long as you call it cam deformity, then really all that matters. We need to remember that not all patients with cam deformity are symptomatic. A study has shown that about 14% of these patients with cam deformity, they actually don't have any symptoms, so they're not always symptomatic. But it's good to mention it, and it's good to report it and document it in the report. You would be able to see this cam deformity, as you said, on the prolateral radiograph. Sometimes you may be able to see it even on the frontal radiograph. So this is a normal hip. When you draw a best fit circle around the femoral head, you should see concavity here at the femoral head neck junction. But in patient with cam deformity, when you place a best fit circle around the femoral head, you get convexity at the femoral head neck junction. So that would be suspicious for cam deformity. Cam deformity can be developmental, as in this patient, for example, is a developmental bony bump, but also can happen secondary to slipped capital femoral epiphysis, as in this patient here. You can see there's loss of that concavity between the femoral head and the neck. The way we quantify the bony bump or the sphericity of the femoral head is by using the alpha angle. And the way to do alpha angle measure it is to place a best fit circle around the femoral head. Then you draw a line along the femoral neck axis, and it then reaches the center of that circle. And then you draw another line which should bisect the area where the circle meets the anterior cortex of the neck. So that's where the second arm of the angle should go. And then you get the alpha angle. So for example, this is a normal patient. This is a patient with cam deformity. The angle is more than 60 degrees, which is abnormal. And normally the area on, for example, MRI, if you were to use the alpha angle on MRI, the best area to do the alpha angle is at 130 or 1.5 o'clock position of the femoral head. Cam deformity, when it is present, it can manifest in what is called the triad of cam deformity. And the triad of cam deformity is the abnormality that we looked at, the bony bump at the femoral head neck junction. And then you also get with it intrasuperior cartilage changes. We get intrasuperior labral changes. So the bony bump with the cartilage changes and the labral changes called the triad. of cam deformity. So here we have a patient with cam deformity. We have herniation pit here at the femoral head neck junction. We see labral tear, and we see some signal change in the cartilage as well. So this is the triad of cam deformity. What are the complications of femoroacetabular impingement, whether it is pincer, cam, or both? The first complication of femoroacetabular impingement is obviously labral tears. And that's because of the abnormal mechanics of the hip joint. So this is a normal hip joint during flexion, adduction, internal rotation. You should have clearance between the anterior cortex of the femoral neck and the labrum. But in patients with pincer and increased acetabular overcoverage of the femoral head, when you do the flexion, internal rotation, and adduction, there is contact between the anterior cortex of the femoral neck and the labrum. And also in patients with cam deformity, because of that bony bump during flexion, adduction, internal rotation, we get contact between the bony bump and the labrum, anterior labrum here, and we get labral tearing. The second complication of femoroacetabular impingement is hip pain. But hip pain is actually not specific to FAI. There are a lot of causes of hip pain, such as bursitis, tendon pathology, inflammatory arthropathy, osteoarthritis, infection, lots of causes of hip pain. But labral tears actually are associated with hip joint pain in about a quarter to half of the cases. So there's a significant incidence of hip pain in patients with labral pathology and FAI. The third complication of femoroacetabular impingement is cartilage degeneration and osteoarthritis. As we can see here, there's cartilage, hyaline cartilage irregularity and signal change. It's a paper again published by the same person, Gans, who looked at femoroacetabular impingement as a cause for osteoarthritis of the hip joints. The association was found to be about 60%, or just over 60% of patients with FAI eventually will develop cartilage degeneration and osteoarthritis of the joint. The cartilage changes in patients with FAI can be quite specific for patients with pincer. Now, in patients with pincer, because the impingement happens here, because of the acetabular overcoverage, the femoral head subluxes posteriorly. And when the femoral head subluxes posteriorly, it causes cartilage degeneration posterior-inferiorly. But in patients with cam, the bony bump itself causes damage in the cartilage at the intrasuperior aspect, which is the area of contact between the bony bump and the labrum. أعتقد توقفنا هنا at the cartilage changes associated with femoroacetabular impingement. And what we said was that in pincer patients, because of the contact between the femoral neck and the anterior acetabulum, what will happen is posterior subluxation of the femoral head, and because of that posterior subluxation, the cartilage changes happen posterior-inferiorly. But in patients with cam impingement, the contact between the bony bump and the cartilage happen anterosuperiorly. So always when we look at the MRI scan of patients with pincer type of femoroacetabular impingement, we look at the cartilage posterior-inferiorly, but in patients with cam type of femoroacetabular impingement, we look at the cartilage changes anterosuperiorly. This is a paper we published at the Canadian Medical Association Journal. And the reason why we published this article is really to raise awareness about femoroacetabular impingement in young adults who present with hip pain. This article was directed to general practitioners and family medicine doctors, so they are aware about the association between femoroacetabular impingement and hip pain. And really what we recommended in this article, that if a young patient presented with hip pain, is always to test the hip joint for femoroacetabular impingement by performing flexion, adduction, and internal rotation of the hip joint. If clinically there was suspicion of femoroacetabular impingement, we would recommend performing a radiograph of the pelvis to assess if there are radiographic features of femoroacetabular impingement. And if the radiographs were also suspicious for femoroacetabular impingement, we would recommend orthopedic referral for these patients. Okay, so now we're going to move on to the second group of the hip impingement syndromes, which are the non-FAI impingement syndromes. The non-FAI impingement syndromes include three entities. It's the iliopsoas impingement, the ischiofemoral impingement, and the subspine impingement. We'll start with the iliopsoas impingement. The iliopsoas impingement is actually a condition which is not long ago when it was described by a group of orthopedic surgeons at the Hospital of Special Surgery in the United States. And what they did was they described what they saw on arthroscopy. So this is a normal hip, taking an arthroscopic view of the hip joints. Here you see the iliopsoas tendon, and here is the anterior surface of the acetabulum. But this is another patient. What they did was they looked at the hip and they saw this congestion, edema, and inflammation at the anterior surface of the acetabulum and the labrum. So they described this as traction injury of the anterior labrum due to the overlying iliopsoas tendon. And they described this as iliopsoas impingement. And these patients normally are symptomatic during flexion, adduction, internal rotation, or called failure. Now we need to distinguish between failure and favor, because failure is associated with iliopsoas impingement, but favor is associated with iliopsoas snapping. So iliopsoas snapping and iliopsoas impingement are two different entities. The orthopedic surgeons, when they described this, there were no radiographic features described on these patients. So then another article was published in American Journal of Radiology, and what they did was they looked at the labrum and the iliopsoas tendon to see if there are any characteristic features of iliopsoas tendon. They looked at the lateral tilt angle. They looked at myotendinous junction edema. They looked at the width of the iliopsoas tendon, and they really didn't find any statistical differences in patients with or without iliopsoas tendon impingement. And then because of that, they did not really look at any imaging features of femoroacetabular impingement. So we published our article in the Journal of Skeletal Radiology, and we described all the morphometric measurements of the hip joint in patient with iliopsoas impingement. These are the measurements we routinely perform on patients with iliopsoas impingement, hip impingement in general. We always quantify the femoral neck anteversion. We measure the femoral neck shaft angle. We measure the acetabular anteversion angle. We measure alpha angle, lateral center edge angle, tonus angle or acetabular index angle, and the acetabular depth. These are the measurements we perform all the time. We have dedicated orthopedic surgeons who perform labral surgery, and they refer patients to us for femoroacetabular imaging, and we perform all these measurements on MRI. So this is how you, for example, you measure the femoral neck anteversion. As you may remember from the beginning when I was talking about the MRI protocol, I said we always image the knees of these patients. And the reason why we image the knees of these patients is because we can assess the position of the knee and then offset that from the femoral neck angle or the version to get the true or the corrected femoral neck version. And so, for example, here, because you have the leg internal rotated by 3 degrees, it means the true femoral neck version is not 5, is actually 8 degrees, because you need to externally rotate the leg by 3 degrees, and that will through the femoral neck in more anteversion by 3 degrees, so 5 and 3. The corrected femoral neck version is actually 8 degrees. And the other measurements we perform, as I mentioned earlier, is the acetabular version. We perform the alpha angle, we perform the acetabular depth angle, the femoral neck and shaft angle, acetabular index, lateral center edge angle. So in this article we published, we looked at all these measurements in patients with iliopsoas impingement. We found no correlation between all these measurements and femoroacetabular impingement of the iliopsoas impingement. So this was a separate entity. The iliopsoas impingement was a separate entity. It has no relationship to the CAM or the pincer type of femoroacetabular impingement. And also the characteristic feature of these patients with iliopsoas impingement, that the labral tears are isolated at anterior 3 o'clock position. So this is the most characteristic feature of patients with iliopsoas impingement. So this is an example of a patient with iliopsoas impingement. We perform a non-orthographic 3 Tesla MRI scan of the hip joint, and you can see this isolated 3 o'clock anterior labral tear. This is the iliopsoas tendon here, and also you can see the labral tear isolated at anterior 3 o'clock position, and this is the iliopsoas tendon. Okay, we move on to a different entity here, and if we have a resident who could look at this as MRI.
اوكي دكتور محمد جهاد.
نعم أستاذ، صباح الخير.
صباح الخير.
An MRI view of axial view and coronal view of the hip, both hip, show there is an abnormal signal intensity seen at the posterior aspect of the left hip joint between the ischium and the femoral head.
Do you know what this pathology is?
It seems to be bilateral, so it is not pathology.
Okay, so we move on to another entity of of hip impingement syndrome is the ischiofemoral impingement. So the first group of disorders in the non-FAI, we said it was the iliopsoas impingement, when the iliopsoas tendon is impinging on the labrum. Now, this is a different entity of hip impingement syndrome called the ischiofemoral impingement. And the ischiofemoral impingement happens when there is a narrowing of the distance between the femur and the ischium. So normally is about 13 millimeter plus minus 5 millimeter, but normally is 23 millimeter plus minus 8 millimeter, but when it is reduced to 13 millimeter, it becomes abnormal and you get impingement of the femur and the ischium. It is more common in women than men, and it can be symptomatic, associated with pain. And the reason why these patients are symptomatic is because when there is ischiofemoral impingement, you get edema and irritation and inflammation of the quadratus femoris muscle. You get also irritation of the sciatic nerve, and sometimes patients may develop pseudobursitis. So this patient that you looked at, for example, there was edema in the quadratus femoris muscles bilaterally, and also in the sagittal image, you see this edema in the quadratus femoris muscle. So always when you see edema in the quadratus femoris muscle, always think about ischiofemoral impingement as a pathology that can be associated with compression of the quadratus femoris muscle. Here we have, again, there's entrapment of the sciatic nerve at the ischiofemoral interval, so it becomes a problem for these patients because they can develop sciatica-like symptoms. Here we have another patient who developed pseudobursitis at the ischiofemoral interval here, actually on both sides. So that's another manifestation of ischiofemoral impingement, which is pseudobursitis. Ischiofemoral impingement could happen for multiple reasons. Could be just spontaneous, where there is medialization of the femur in relation to the ischium. It could happen also following total hip arthroplasty, as in this patient, and also may happen following osteoarthritis of the hip joint or protrusio acetabuli. And as you can imagine, when there is a protrusio acetabuli, there is migration of the femur centrally, and that brings the femur closer to the ischium, and these patients may develop ischiofemoral impingement. Okay, now we have another case, and if we have a resident who could look up this case.
دكتورة دينا حامد.
نعم أستاذ، صباح الخير.
صباح الخير.
AP pelvis, X-ray of the hip and frog lateral of the right hip. There is a prominent anterior inferior iliac spine on the right side with the possible avulsion fracture seen on the frog يعني lateral view. This is a type of impingement when the hip is flexed يمكن تسمى subspine impingement.
Yeah, fantastic. Yeah, it's subspine impingement. Yeah, fantastic. So subspine impingement, it happens as a result of, like you said, avulsion fracture of the anterior inferior iliac spine. So we have another example here. There is quite a bit of bulge of the anterior inferior iliac spine. And the reason why avulsion fractures happen in this area is because it's the origin of the straight head of the rectus femoris muscle. And the rectus femoris muscle is actually one of the strongest muscles in the quadriceps compartment. And because of that, most of the times we see these fractures happen, particularly in soccer players and sport sprinters fracture, when you see a avulsion fracture of the anterior inferior iliac spine. And this appearance also can be described as the pelvic digit or the iliac rib. So this terminology can be used for this entity, the subspinal impingement. And basically it's all remodeling and protrusion of the anterior inferior iliac spine due to prior bony injury and fracture. And as I mentioned quite correctly, what happens is that during the flexion of the hip, the femur comes into contact with this, and that's how we develop subspinal impingement. And again, we have this one that you just looked at, another example of subspinal impingement or iliac rib here. On MRI scan, you can see this pelvic digit or iliac rib with associated edema due to prior avulsion fracture of the anterior inferior iliac spine. Okay, so that's really the end of the talk. It's a little very specialized hip imaging because it's only dedicated for the labrum, but labral pathology and labral tears and mechanical disorders of the hip joints are common. We just need to be aware of them. And many patients actually present with hip pain and remain underdiagnosed because of lack of awareness of the labral pathology, lack of awareness of the clinical presentation of femoroacetabular impingement or the non-FAI impingements. Sometimes also lack of awareness from radiologists about the radiographic features of femoroacetabular impingement or the non-femoroacetabular impingement cases. So yeah, we focused on all these imaging appearances. We talked about the labral pathology, labral anatomy, MRI protocols, and different clinical appearances and radiographic appearances of hip impingement syndromes. So thank you for listening, and if you have any questions, please go ahead.